Good afternoon, everybody. My name is Lyuba Vartikovsky. I am at the National Cancer Institute, and my husband is getting better, but not well enough to come here today. So hopefully next week he will be back in full force and continue with the course of Demystifying Medicine. So welcome to the second session of the Demystifying Medicine today. And please sign in to the book, which is being circulated around. And those of you who would like to obtain a certificate, if you attend 50% of the courses, you can pass a final exam, which I assure you is not going to be very difficult. And you receive a NIH certificate of Demystifying Medicine. Unfortunately, to our schedule, Dr. Frey could not be today, so we have his colleague, Dr. Nirali Shah, who will be the speaker for today's session. So the notes, references, and her PowerPoint will be available online within a few days for everybody to download, as we usually do. As a background of today's session, I would like you to refer to a book, a brilliant book by Siddhartha Mukherjee, who won a Pulitzer Prize for this book in 2010, the book on Emperor of All Maladies. And he actually gave a talk on this book the following year here at NIH. As he points out, and we all know, that the history of cancer is the most dramatic in medicine in general. And we can say that up to somewhere in 20th century, the only resource for patients with tumors was surgery. And the results, of course, were terrible. And the global view at that time was stated by a poet, Hilary Billock, who I will read you a short paragraph. Physicians of the utmost fame were called at once, but when they came, they answered, as they took their fees, there is no cure for this disease. By the middle of 20th century, not much changed. Surgery was still in the lead, and radiation therapy was introduced with somewhat success in some cases. But the most importantly, there was no new concept for therapy of cancer. The overall view was that of William Castle, a very famous professor at Harvard Medical School and the discoverer of pernicious anemia. Palliation of cancer is our daily task. The cure is a fervent hope. So because the therapy was really of not much of help, cancer largely fell in the hands of the pathologists. One of the most important persons in that field in the middle of 1800s was Rudolf Virchow, a German pathologist who decided to classify all tumors according to their cell type. By the time he died in 1902, he classified all solid tumors by their cell of origin. He differentiated acute and chronic tumor types and called cancer of the blood leukemias. Virchow's other very important and seminal contribution was that he described cancer as tumors of unrestricted growth. Until recently, these morphologic characteristics and unrestrained growth has been our paradigm for cancer identification and decisions on treatment. Of all tumors, leukemias are the most terrifying, especially acute lymphocytic leukemias, ALL, which are often arise in young children. Then later in life, AML, acute myelogenous leukemia, in adults, takes the same mantle. A major conceptual breakthrough occurred in 1950 when another pathologist, Emil Frey, who decided to take in his hands therapeutic approaches, decided that perhaps B12 and its companion, folate, are responsible for maintaining growth of acute leukemia in children. Initially, he approached this concept as giving folate to children with acute leukemia. Of course, the results were disastrous. Tumors grew much faster. Then he convinced the establishment with great difficulty to allow him to try the opposite approach, to deprive the tumors from folate. So few children were accepted, and their parents and the children accepted to be treated with aminopterin, which is a competitive inhibitor of folate. Amazingly, some of the tumors regressed, and few, although transient, responses were obtained. This was the dawn of the whole concept of chemotherapy for cancer. And this was followed by multiple trials at the National Cancer Institute by Frey and Friedrich in subsequent years. And they expanded the concept of chemotherapy. Most of these trials, again, were done in children and were really focused on acute leukemia in children. And there was the beginning of balancing single, multiple therapies, and balancing the toxicity and the benefit of therapies. Of course, the most recent studies, more familiar to us, is in molecular oncology and molecular methods which we apply today. From this, we have learned that morphologic identity does not imply functional identity. Molecular heterogeneity of a tumor confers different function, and these concepts began to shape our concept of individualized therapy and targeted therapies. The most successful of which has been chronic myelogenous leukemia and the discovery and development of unique specific tyrosine kinase inhibitor for BCR-ABL translocation. In the present, advances continue at a rapid pace. They now involve advanced chemotherapeutic, personalized medicine based on molecular genomics, and more recently, interplay with the immune system. So we welcome Dr. Shah, who we trust will update us on the exciting world and challenges in cancer biology, and also inform us whether acute leukemia, particularly in children, can be cured. Dr. Shah is an associate professor, research physician in pediatric oncology at the Center of Cancer Research at NCI. She received her MD at the University of Illinois College of Medicine in Chicago in 2004, did her internship and residency at the combined program Boston College and Mass General Hospital and Children's Hospital, where she was also a chief resident. She joined the Pediatric Hematology and Oncology Fellowship training and stayed at the National Cancer Institute. She is now an associate clinical investigator. Dr. Shah's work focuses on clinical trials using immune-targeted therapies, targeted difficult cases of relapsed and refractory acute leukemia in children. So please join me in welcoming Dr. Shah.
Thank you so much for that very kind introduction. All right, so as mentioned, my talk today will focus on childhood leukemia and to discuss the challenges and milestones in current approaches. I have no disclosures to report, and the objectives for today will be to provide a general overview of pediatric ALL and the current treatment approaches, to review the advances in immunotherapeutic approaches for the treatment of ALL, and to discuss the future directions and challenges in immunotherapy for ALL. So to help me with this, I would like to introduce you to some of our patients, and I would like to just state that all of the patients and or parents have provided consent and assent or permission as appropriate to share their pictures and their stories to help us go through this discussion today. Our first patient is BJ. He is an 18-year-old male who was diagnosed in October of 2015. Previously healthy, no known risk factors, is away at college, doing well as a freshman. He's a friend to all. He's a beloved son and a brother. He first came to us at the age of 19, having failed standard of care therapy. Our next patient is MN, who was initially diagnosed at the age of 3.5, standard risk ALL. She was diagnosed in March of 2012. Again, previously healthy, no known risk factors. Really standard risk sort of fit the standard age and demographic population for standard risk ALL. She loves to dance and is the heart and soul of her family. She came to us at the age of 8, again, also having failed all standard approaches. And our third patient is Sonny. He's a 6-year-old male who, when he was initially diagnosed in June of 2012, also previously healthy, no known risk factors. He presented to us when he was 12 with a love for Xbox, food, all sorts of challenges in the gifted and talented program, is a loving brother and son. And these patients are going to be the ones who guide us through what the current therapies are for leukemia, what the future, where the future is going. So just to give you a little bit of background, I think it's important to start off by just the concept of what are lymphoblasts. So again, lymphoblasts are part of the adaptive immune system. You're going to have your myeloid stem cells, you'll have your lymphoid stem cells, all originating from your hematopoietic stem cell progenitors. Does that pointer work okay? Yep. And so lymphoblasts are basically, leukemia is where you have an aberrant overgrowth of either B-cell lymphocytes or T-cell lymphocytes. I will primarily, for the purpose of this talk, be focusing on B-cell lymphoblastic lymphoma or B-cell lymphoblastic leukemia, and we'll just touch a little bit on T-cell lymphoblastic leukemia. So childhood acute lymphoblastic leukemia, also called ALL, is the most common cancer diagnosed in children. Represents about 41 cases per million in children less than the age of 14. Also is up and seen in the adolescent and young adult population, about 17 cases per million in teens between the ages of 15 to 19. This translates to approximately 3,000 new cases per year, and it's 25% of all new cancer diagnoses. Using standard risk-adapted approaches and combination chemotherapy, 85 to 90% of newly diagnosed patients will be cured. And ALL really represents the poster child for the efficacy and the importance of cooperative group participation and enrollment in clinical trials. When you have a disease that's, even though it's the most common diagnosis compared to all cancers overall, childhood leukemia is still quite rare, and to be able to really improve the diagnosis and prognosis overall, you need to be able to study these in large groups. Shown here is the improvement in survival by study error. You can see here the outcomes of ALL in 1960s, 1970s that has continued to grow to the point where we are currently at looking at an 85 to 90% cure rate. This was mentioned just briefly. So the origin of ALL therapy, again, there is this observation that folic acid agonists actually led to an acceleration of the leukemia progression. And so this is the original report in the New England Journal of Medicine that described 16 patients, of whom 5 of the children who were treated attained a temporary remission with the use of folic acid antagonist, aminopterin. And this, again, really was the foundation for chemotherapies for ALL. The current treatment plan uses combinatorial chemotherapy treatment strategies with non-competing mechanisms of action. It involves a series of intensified, de-intensified treatment cycles with a prolonged maintenance phase lasting 2 to 3 years, and again incorporates a very risk-adapted approach. This here is a little mind-boggling to look at it, so I just give this to you just to give you an example of what we do when we have a patient who's newly diagnosed. We evaluate them. They all get a standard induction therapy, which is based on a 4-drug induction regimen. You can see here the standard chemotherapy agents, which consist of vincristine, dexamethasone or some form of steroid, as well as pegosparaginase. You also get intrathecal chemotherapy. There may be a 4th agent added depending on the high risk of their disease. And then they go through then subsequent phases of, again, intensified or de-intensified treatment regimen that consists of consolidation, interim maintenance, delayed intensification, interim maintenance, followed then again by several weeks of maintenance therapy that spans over the course of 2 to 3 years. Again, it is a very much a risk-adapted approach where you can go on a higher risk arm or a lower risk arm based on several risk factors. So those risk factors, the standard NCI risk factors are based on your initial age at diagnosis and your initial presenting white blood cell count. So if you're between the ages of 1 and 10 and you present with a white blood cell count of less than 50,000, you'd be considered standard risk. And when a patient comes in who's newly diagnosed, that's really often all you'll have, along with the disease phenotype, to be able to tell you that it is truly ALL, so again, a lymphoblastic origin versus AML, and not myelogenous origin. And you'll be able to get a sense of whether it's a B-cell lymphoblastic leukemia or a T-cell lymphoblastic leukemia. And that will be given to you, again, on your initial evaluation. Other risk factors include whether or not there is central nervous system disease involvement, testicular involvement, whether there's a history of Down syndrome in the patient, the sex of the patient, with, again, the thought being that male patients tend to do less well, race and ethnicity. A lot of this also has to do with thinking about long-term compliance. The immunophenotype, B-cell in general is more favorable than T-cell, which can be harder to treat, and T-cell leukemia will also present more frequently with a lymphoblastic lymphoma, so again, a lymphomatous presentation over a leukemia presentation. We also look a lot at the cytogenetics. Again, none of these would be available at your first day that the patient comes in, but you find this out over a period of time. So are they Philly chromosome positive? Do they have the translocation 922? Are they MLL rearranged? Or KMT2A, which again involves the 11q23? This specific population will involve some patients who have what's called infant ALL, so they are diagnosed at less than 1 year of age and have an extremely poor prognosis, with features that often are a little bit more stem cell-like in presentation. ETV6 RUNX1 or TAL-AML is the most commonly seen ALL translocation, again, usually a favorable prognosis. Are the patients hypodiploid or hyperdiploid? Hypodiploid, again, very, very poor prognosis and would be an indication that these patients might need to go to stem cell transplant after achieving a first remission, or hyperdiploid, meaning that they will likely do well. And as we learn more about the molecular aspects, there's what I consider sort of the newcomers that are making their way into the field in terms of helping to define the prognostic implication. So there's a group of patients who, although they lack the Philly chromosome and that exact 922 translocation, they do quite poorly and seem to mimic the patients who are Philly positive, but they have been termed PH-like. This includes patients who are CRLF2 rearranged or have the JAK2 mutation, and as well as another group of other cytogenetic abnormalities. Others will also include amplification of 21, and I won't go through it in further detail, but again, we look at a lot of this to help determine prognostic value. Another very, very important risk factor is what is their response to initial therapy. So again, all patients will get a standard induction based on whether they're high risk or standard risk, will consist of a 3 or 4 drug induction regimen. The expectation for patients to be in standard risk is that they're able to clear all evidence of disease by day 8 or by day 21. And by all evidence of disease, I mean not only by morphology, meaning you look under the microscope and you see less than 5% leukemia blasts, but now we're using more sensitive methods of detection that include flow cytometry, and are able to really achieve what we considered minimal residual disease negativity by day 8 in the peripheral blood, by day 29 or day 28 in the bone marrow. And that also determines whether at that point the patients are stratified to a low or a higher risk regimen to try to really reduce their risk of, to improve their overall survival and reduce their risk of relapse. So the current challenge is that although there is an 85 to 90% cure rate, being that it's the most common childhood cancer, that still represents 10 to 15% of patients who are not cured. This represents approximately 2% of patients who are considered initially primary refractory. They will not respond to standard upfront chemotherapy, and also would have relapsed disease. And again, curative options for this population remains a therapeutic challenge. If you're standard risk ALL, you fall into that standard risk age category, you will likely do well, but outcomes for the adolescent and the young adult population, again, really remain quite poor. Some of this may have to do with the treatment that they're designated. Adult patients who are newly diagnosed with ALL will get potentially less intensified therapy than pediatric-inspired regimens. A lot of this has changed, but even when you give adolescent and young adults in pediatric-inspired regimens, their outcomes are still not quite as well. They tend to have more toxicity from the same pediatric-based regimens. They also don't do as well, speaking to the fact that the adolescent young adult population probably have cytogenetics or molecular abnormalities that make them more predisposed to a higher risk stratification. Even though we have a high cure rate, the toxicity from cumulative therapy is not insignificant. They get a lot of steroids, they get a lot of neurotoxicity from intrathecal chemotherapy. Some patients may require central nervous system radiation therapy. If they have relapse disease, often you will go to stem cell transplant, which is life-altering. So these therapies are the burden and their long-term quality of life is not insignificant, and clearly novel therapies are needed. So to go back to our patients and why they came to us, so BJ, again, presented at the age of 18, so from what I said before that he was high risk by age. He fell outside that standard age category. He also presented with a very high white blood cell count of 121,000. Going through his response, so he was treated on, again, a pediatric regimen, and his response to therapy was very suboptimal. He had end induction evidence of disease. It was low-level disease. He was considered a morphologic remission, which would be defined as less than 5% disease, but still had high-risk disease. At that point, he was put into the high-risk stratification, and after receiving an intensified cycle of chemotherapy, his disease burden actually increased, showing that he truly was chemotherapy refractory and sort of fell into the category of almost a primary refractory patient. who was standard risk at therapy, she also had a response to chemotherapy that was suboptimal, with end induction disease that was positive and detectable, and she was then stratified to a high-risk arm to which she did respond. And she continued on therapy only to relapse sort of at the tail end of maintenance therapy with isolated CNS disease. And again, Sonny, standard risk at presentation, had a very nice response to upfront chemotherapy, but again, relapsed towards the very end of therapy, just towards the tail end of maintenance or shortly after completion. So again, these patients at that point define themselves as having failed standard therapies. So taking you through sort of what's happened and why the times are so exciting right now. So again, you had all the standard chemotherapies that I have very briefly touched on. And then there was a very long period of time where there really haven't been a lot of new therapies approved. So clofarabine came along in 2004. It was the first new therapy that had received FDA approval for treatment of ALL in children. It's a purine nucleoside antimetabolite, works in conjunction with all of the other chemotherapy agents. It's really quite, I will say it's very, it is hard to tolerate this chemotherapy, but again, did have a complete remission rate of 20%, which at the time, and again for early phase study, was quite impressive and led to its FDA approval. T-cell ALL had coming its way Nirali, which is also a purine nucleoside antimetabolite. It's associated with a fair degree of neurologic toxicities, but again, led to about a complete remission rate of 20%. I'm going to have you keep the 20% in mind to give you a comparison of where we are now. And then there's nothing new or novel that has come really in almost a decade. So what was happening over this period of time between 2004, and I'll talk about Marquibo in just a second, between 2004 and 2014, is that people basically used the standard chemotherapy regimens that were available and either tried to intensify, de-intensify based on where you were at the risk stratification to see what you can do to reduce toxicity for patients who are likely to do well and be in a long-term remission, intensify therapy for patients who are likely to not do well, who you are trying to salvage, with the only agents really being clofarabine and Nirali. Vincristine sulfate liposome injections is worth noting. So this is a liposomal formulation of vincristine, received FDA approval for only adults in 2012, and we're currently working on a trial trying to get some pediatric experience with Marquibo. We actually ran the first phase 1 pediatric study using this agent to determine the pharmacokinetics of this agent, and currently have a trial where we're using it with combination chemotherapy. But again, it's sort of a newer package of an old drug, and the purpose of this was to really try to intensify the therapeutic index of vincristine, which currently has a max cap on it based on your size due to its neurotoxicity. So you can only give a certain amount of vincristine at some point if you're, regardless of how big or how small you are, you sort of have a max dose, because beyond that dose, it was determined on a prior study that you were not able to optimize that dose due to the neurotoxicity. So again, all of these drugs led to about a complete remission rate of 20%, with the most recent one really being in 2012. So to talk, before going into the next part of the talk, it's a little bit important to talk about what's on the cell surface, because the rest of this presentation will really focus on immune-targeted therapy. So this takes you through different B-cell surface antigens in what you see. And I have to thank Kathy Calvo and give her credit for this slide. So CD19 is something that you're going to see throughout. It's a pan-B cell marker. This becomes very important when we think about targeted therapy for B-cell ALL, particularly pre-B ALL, which is seen in childhood leukemia. CD20, you'll see, is not seen quite so commonly in the pre-B. We'll have maybe about 50% of the cases be positive for CD20. This is something you may see more in patients with later stage lymphomas, also in adult lymphomas. And then CD22, which I'll talk a little bit about, tends to track right along CD19. But again, CD19, just remember, it is a pan-B cell marker. It is found on the surface at high level expression on pre-B ALL, which makes it a very good target for targeted therapies. Again, you'll see here, because of what we're targeting in terms of the precursor B ALL or lymphoblastic lymphoma, we tend not to have immunoglobulin present as well. That usually happens in a more mature B cell. So talk through immunotherapy for ALL. So again, utilizing what is on the surface of the B cell. You can either have a naked antibody, you can have a conjugated antibody, you can have a bispecific antibody, in which case would serve as a synapse or a CAR T cell. I'll walk you through this slide just a little bit slowly. Please let me know if there's any questions. So naked antibody is basically just that. It has the scFv without being conjugated to anything, and basically uses the ADCC to try to utilize some killing mechanisms. Again, you can have, alemtuzumab targets CD52, rituximab targets CD20. There's less of a role for that in pre-B ALL, where only about 50% of the leukemia will be CD20 positive. So again, you might only be targeting a partial population. And apertuzumab was the first of its kind targeting CD22. They tend to have some efficacy, not complete efficacy, and it really have not moved forward all that much in pre-B ALL. Conjugated antibodies are basically taking the same concept of the scFv, targeting a specific antigen that's found on the leukemia cell surface, and combining it with either a chemotherapy or some type of conjugate that would lead to cell death and or apoptosis. Inotuzumab, I'll talk a little bit later about, is conjugated to calicheamycin. It follows along the same lines of Mylotarg or gemtuzumab, if you're familiar with that drug, in AML, which is a CD33 target, which is again combined with calicheamycin. It goes into the cell, releases a calicheamycin, and then leads to cell death and apoptosis. Blinatumomab is first of its kind, and that is a bispecific T-cell engager where it combines, I sort of think of it serving as a synapse. It combines targeting of CD19 as well as targeting of CD3, where it brings a T-cell in close proximity to the B cell, utilizing that to help kill the leukemia cell. And then CAR T cells, again, which I'll focus the rest of my presentation on and spend the most time with, is basically where you're taking the functional properties of an antibody-based targeting with the capacity of a T cell. Again, primarily most of our data is in targeting CD19 as an antigen, but I'll talk about what we've been doing in the pediatric oncology branch targeting CD22. So inotuzumab. So this is an anti-CD22 conjugated antibody that is conjugated to calicheamicin. This is the New England Journal of Medicine paper that basically led to its FDA approval that showed that when it was used as a single agent in comparison to standard chemotherapy for almost all of the different subgroups, it led to a favorable outcome. It was quite well tolerated and had quite impressive single agent efficacy. There's one subgroup where it does not have demonstrable efficacy in comparison to standard chemotherapy, and that's actually the MLL subtype. If you can just hold on to that thought, I'll get to that in a couple of minutes. But remember that, again, it's the MLL patients who do not respond as well to inotuzumab, which is a CD22 targeted therapy. There is currently an ongoing pediatric phase 2 study that is looking at using inotuzumab in the pediatric population to see if these results can be replicated in children. Thus far, we only have retrospective data for use of inotuzumab in this study, in this population. Blinatumomab, as I mentioned, is a combination of an anti-CD3 antibody and anti-CD19 antibody that, again, leads to bringing the T cell close to the B cell and allowing for direct lysis. Led to about a 50 to 70% complete remission rate in adults and a 30 to 40% complete remission rate in children. The explanation for the lower efficacy rate in children is thought to be that the pediatric patients who come to this therapy are likely more heavily pretreated, likely have lower T cell counts than the adults who probably went to blinatumomab a little bit earlier in their course, likely have healthier T cells to engage and be active, but again, some of that really has to be explored. So going back to our slides about the FDA approval, so again, we're entering a very, very exciting era. So, 2004, 2005, there's a huge gap. Then we have Markiba that comes along again, which is sort of a reformulation of a standard chemotherapy. And finally, we have blinatumomab that got accelerated approval in 2014, with finally having regular approval in 2017, with having approval in both adults as well as pediatric. Inotuzumab recently got FDA approval, I believe, in August of this past year. It's currently approved in adults only, with a plan for an ongoing COG study to help lead to the pediatric indication for use of this agent. I mentioned with clofarabine, nelarabine, and liposomal vincristine that we were looking at a complete remission rate of about 20%. We've now taken these novel therapies and showing single agent efficacy ranging from about 40 to 50%. With a very different toxicity profile. So again, the therapies are really changing over time. So CAR T-cell therapy is really what I'll be focusing this part of my talk on. So what is a CAR? It stands for chimeric antigen receptor, and it is retaining the functionality of a T cell, incorporating the antigen recognition properties of an antibody. And it's a customized receptor where you're taking the extracellular antigen binding domain with the intracellular signaling domain of a T cell. I'll focus mostly on the second generation CAR signaling, which is what we're using now. Again, you have the scFv. With the co-stimulator, you have a signal 1 and a signal 2 from a T cell, and redirecting that to recognize antigens that are found on leukemia cells. Please note that they're not specific to differentiating CD19 positive leukemia cells from CD19 positive normal B cells. So they will attack both normal B cells as well as abnormal lymphoblasts that are CD19 positive. So in terms of making a CAR T cell, so these cells are taken from patients themselves. A patient would undergo an apheresis for collection of the lymphocytes. The lymphocytes are then put into culture. They're stimulated and transduced either using a lentivirus or a retrovirus to introduce the vector. The cells are then expanded in vitro. The patient, in the meanwhile, while these cells are, so again, you can see here, day 0 to 2, you have stimulation activation, you have the transduction, you have the expansion phase, anywhere from a couple of days to weeks, depending on who is making the CAR T cells. And basically, you plan to give the patient lymphodepleting chemotherapy to set them up for a milieu to accept the CAR T cells at the time of infusion. And that can consist of anywhere from a 3 to 5 day regimen that typically includes fludarabine and cyclophosphamide, both are which highly lymphodepleting. The goal is for this chemotherapy to be lymphodepleting, not necessarily anti-leukemic effect. And the chemotherapy is given, and the CAR T cells are then infused on day 0. And then you have infusion day, like this sort of bench to bedside. It does go through some processing, and it is these cells are made in our cell processing section, and they essentially come up in a syringe like this, again 30 cc's, and that's when you wait. So one of the main side effects of the CAR T cell therapy is what's called cytokine release syndrome. So essentially, patients will get the CAR T cell infusion on day 0, and not a lot will happen. It's fairly not, sort of anticlimactic in that regard. They get the CAR T cells, they usually do well, maybe a slight fever at the time of infusion, and then you wait and you wait and you wait. And we use inflammatory markers to help guide to see what's happening with the CAR T cells, and then you start to see the C-reactive protein, which tends to be a proxy for IL-6, which is again one of the cytokines that is released at the time of these cells expanding in the body and being activated. And then patients who are responding will have what's called cytokine release syndrome. Cytokine release syndrome is a multi-system inflammatory response that mimics sepsis, but is different from that. Going through the different systems, our patients will have neurologic complications that can range from just headaches, changes in levels of consciousness, delirium, to having hallucinations, tremors. In very severe cases, they may have seizures. There have been at least two cases, I think there was a third as well, of another CD19-based CAR T cell therapy that led to fatal brain edema. Again, the full etiology of the neurologic toxicity in the setting of cytokine release syndrome is not completely elucidated. It's under exploration, but the thought there may be that there is either some disruption of the blood-brain barrier, or endothelial activation that is leading to disruption of the blood-brain barrier, leading to increased inflammation in the or inflammatory cytokines in the brain that's leading to this neurotoxicity. Constitutionally, these patients are getting high fevers, so we're seeing fevers in the range of anywhere from 103, 104 up high as 107. So again, some of the delirium may be just even related to them having these high fevers, tremors, generalized malaise. They look like they have the flu. Just generalized achiness all over, arthralgias. We will see some cardiovascular side effects. We have had patients, drop their ejection fraction, require blood pressure support, have low blood pressures. They'll have, some of our older patients may have sort of a leak in troponin indicating that their heart is undergoing some strain. We are actively prospectively looking at the cardiac toxicities of our patients who receive CAR T cell therapy, and they were hoping to at least figure out exactly what's going on with these patients. They may have pulmonary toxicity. That's the evidence in the setting as tachypnea and hypoxia. Again, these patients may get a lot of fluid resuscitation as part of the low blood pressure. But I'll also say from our personal experience, for patients who have, by the time the patients come to us, they've really exhausted all of their therapies. They may have disease that is evident in their lungs. They may have malignant pleural effusions, and I have found that those patients are the ones that have the most difficult time because the CAR cells are going anywhere that there is leukemia. And so if you have lungs that are filled with leukemia, those are the patients who tend to have the most difficult time because, again, there's a lot of inflammation in the process of the CAR T cells killing the leukemia cells. They may have acute kidney injury, all sorts of electrolyte abnormalities. We chase these for days. Diarrhea is a very common presentation. Remembering it's a whole body systemic response. Hematologic abnormalities, we may see some patients have a disturbance in their bleeding and their clotting cascade, and this is something we have to watch very closely because, again, they're having high fevers, they have low platelets, low blood pressure, they may be bleeding. So again, it's something that you have to understand. This therapy is extremely effective. But for this reason, it's really only given in specialized places where folks have the experience of knowing how to deal with this. This cannot be dealt with the same way as you would standard infection sepsis, because if you do that, you end up having a lot of fluid overload and causing more complications for the patients to get that off. So these patients are managed very closely and very carefully. One of the therapies that we have found that works quite well for cytokine release syndrome is an agent called tocilizumab that was initially used in autoinflammatory diseases. Tocilizumab is an anti-IL-6 receptor blockade. So again, in the process of cytokine release syndrome, you see very high levels of IL-6. Tocilizumab, by blocking the receptor, really prevents the IL-6 from affecting the end organs. And usually we give patients, we have a grading system for severity of how severe the cytokine release syndrome is. And now that we know it, and we know that tocilizumab will help to reduce the side effects of cytokine release syndrome, with some early data suggesting that giving it will not reduce the efficacy of the CAR T cells, we're tending to give the tocilizumab a little bit earlier, and you'll find that usually within hours, the fevers go away, they're feeling better, you sort of keep them out of trouble, and are still able to have the efficacy that you want. So I see us moving forward CAR therapy by trying to figure out ways to make this therapy more safe so that our older patients and those patients who have gone through a lot of other therapies are able to tolerate it better. So in terms of the world of CD19 CAR clinical updates, so a lot of this really started evolving right around, probably the earliest trials were in 2012. And there are at least 3 centers who sort of simultaneously led a CD19 CAR-based studies. We were one of those centers, and our results were published in Lancet in 2015. Based on our trial, we took all comers, and so our 67% complete remission rate represents all patients who were enrolled on study, whether we were able to manufacture CAR T cells or not. From this study, we learned that there are some patients that you would not be able to manufacture CAR T cells from. We found out that clofarabine, which used to be given more often, is extremely toxic to lymphocytes, such that if you gave a patient clofarabine, you may not ever be able to have a good quality T cell to be able to manufacture them and have those T cells expand and grow to what they needed to be for a CAR T cell. We also learned that there are different things about patients that would make them more or less responsive, but we did find that all responders had cytokine release syndrome, and showed here is a waterfall plot that shows, our patients who had progressive disease is designated by the red, are patients who ended up having complete remissions. We also had a fair number of patients who on this trial, after attaining a complete remission, were actually used this as a bridge to a curative transplant and are continuing to be long-term survivors. So it's really exciting. Again, we talked about clofarabine and nelarabine and marquee having about a 20% complete remission rate, going to blinatumomab and inotuzumab, approaching now, maybe 40 to 60%. CAR T cells really looking to about 70%, and if you're going to have CRS, it's about a 90% complete remission rate. Concurrently, at the same time that we ran our trial, Children's Hospital of Philadelphia also had a similar CAR T cell trial. Theirs was based a little bit differently. They had a more persistent CAR. Our CAR was a little bit shorter, persistent, similar efficacy. They had a 90% complete remission rate. Again, their 90% is based on only patients who were able to have a CAR T cell product manufactured. Again, all of their patients did have cytokine release syndrome. And then subsequently, there was a global CD19 CAR, which was a registration trial that led to its FDA approval. It was called the Eliana Trial. And of that, there was an 82% complete remission rate. So of the 50 patients who were able to receive a CAR product, 41 were attained at CR. Basing on an intention to treat, so of all those who were enrolled, and that includes patients who were either enrolled and were not able to get to CAR T cell therapy because they got too sick in the interval to receive the CAR T cell therapy, or who were not able to have a product successfully manufactured, that rate does come down to about 65%. But again, I have to speak to the fact of how unbelievably remarkable this is. These are patients who are on these early phase studies. These are phase 1 trials. Keep in mind that phase 1 trials in the clinical trial world is only designated to look at safety and toxicity and tolerability. And to achieve a complete remission rate, looking at, we would say phase 1 trial is successful if you have a complete remission rate of 20 to 30%. That would say that you have a good enough indication of what we would consider going to a phase 2 trial. To have these exciting results in phase 1 therapies, it's unheard of, and really, we're entering a completely new era of targeted therapies in the treatment of ALL. So, with that, there are 2 2 CAR-based therapies that are FDA approved. Chimera, which is the Novartis-based CAR, which is, again, the trial that I just described at Children's Hospital of Philadelphia and was a global trial. This is FDA approved specifically for children up to the age of 25. This CAR is now available, again, at specialized centers where they have CAR therapy and they have the experience to make these CAR T cells and to specifically treat patients with CAR T cells. Tocilizumab, which I described, also was an agent used for autoinflammatory diseases, also concurrently got FDA approval for the treatment of CAR T cell related CRS, which is what we're now using it for. And then the third agent, this is based on a KITE trial, which was actually, those original studies were conducted at the NCI by Jim Kokendorfer and Steve Rosenberg. They used in adults with diffuse large B-cell lymphoma, which is what the FDA approval is for. So again, all 3 of these received FDA approval in 2017. This CAR specific was the one that we used in our ALL trial. And again, complete remission rates of anywhere from 50 to 80%. So will CD19 CAR be the answer? So this is Emily Whitehead. She was the first pediatric patient to ever receive CAR T-cell therapy. And her course was incredibly remarkable. She had failed all therapies, had not received a prior transplant. She was basically told to go to palliative care because her leukemia was not responding to standard therapies. Went to Children's Hospital of Philadelphia, got her CAR T-cell infusion, and within days was incredibly sick. We did not know about tocilizumab. We did not know it was going to work. She was sort of on death's door on multiple agents. She was intubated on multiple agents to support her blood pressure, and somebody there had the idea, well, why don't we check cytokines? Turns out that IL-6 was elevated. Someone said, well, I know about tocilizumab, gave it, and she immediately turned around. Had this first patient died in pediatrics, I think we would have had a very, very different course. I personally, I get goosebumps even talking about it, being a clinical person, to just talk about the excitement of seeing this in real time happening and how different the outcomes could have been. But this really sort of paved the way for us to be able to move this therapy forward in children. Keep in mind, in clinical trials in general, you typically treat adults before children. Clinical trial development in children typically lags behind because you're waiting, again, you're sort of ethically bound to treat adults before children. And this is a story where, I think pediatrics has really led the field in terms of being able to treat children who have the disease. So she received her CAR T-cell therapy in 2012. She will be almost 6 years out. She is in an ongoing remission with no additional therapies. Typically for patients who have relapsed refractory disease like this, once they attain a remission, they would subsequently go on to stem cell transplant. At the time she'd gone through so much, the family decided to wait. They continue to wait, and she continues to be in an ongoing remission and is a spokesperson for a lot of our patients and families. But will it work for everyone? So unfortunately not. So there is antigen loss. So we are learning that over time, leukemia tends to outsmart whatever therapy you give it. So just like the experience with the folic acid antagonist that led to very, very brief transient remission, and what led to the paradigm of combinatorial chemotherapy approaches to treat leukemia, you need to, chemotherapy would outsmart one therapy. Similar to this, when you target just CD19, be it blinatumomab, be it CD19 CAR, there will be a proportion of patients who will relapse with the CAR still actively present, but who have become CD19 negative. And we'll talk more about that. CAR T-cell failure. The CAR T-cells may go away. They may not be persistent. What level of persistence do you need to provide ongoing surveillance? We don't really know, but again, that could be another cause of relapse. Inability to collect cells, and I'll add to that also the inability to manufacture cells. We know that certain chemotherapies, if you give them, it makes it very difficult to have a quality T cell that will have the ability to grow and expand. For some patients, by the time they come to us, their lymphocyte counts are so low. Again, the entire therapy for ALL is directed at targeting their lymphocytes. And you need to have an adequate lymphocyte recovery to be able to collect T cells that are healthy enough to be able to transduce and manufacture into CAR T cells. And so there's a proportion of patients for whom this therapy is not currently possible. And then fatal neurotoxicity or cytokine release syndrome. I think we're learning over time about how to manage these patients. I will say personally from our experience, we used to wait and wait and wait before we gave any intervention to reduce the side effects of cytokine release syndrome. Seattle has really led the efforts in this regard. They have prospectively studied early interventions with steroids and or tocilizumab to reduce the inflammatory response, and have found that mostly they're able to ameliorate the intensity of the cytokine release syndrome without impacting the efficacy. And I think we all need to study this a little bit more prospectively so that we can really have the efficacy that we want without having to make our patients terribly sick. So again, I think that there's a lot that needs to be learned. There's about a 30 to 40% relapse rate that is reported. I think the number is probably higher as we get more longitudinal data. Again, keep in mind that the earliest patients received CAR T-cell therapy in 2012. So we are just now approaching 6 years. And so the relapse rates are probably closer to 40 to 50% for a host of reasons. So what happens to CD19? So there's been at least one identified mechanism, and I'll walk you through this slide. So again, this is your full-length CD19. To walk you through this image, which comes from the group at Children's Hospital of Philadelphia, you have the extracellular domain with your full-length CD19. This is something that you can target that can be seen by the CD19-directed CAR. You have your transmembrane domain and you have your cytosolic domain. And so at least one identified mechanism for CD19 loss and evasion of the active CAR is that there is loss of the surface epitope, but you still have retention of the target protein. This is due to clustering of nonsense and missense mutations in exon 2 of the CD19 that leads to a frameshift mutation that eliminates the full-length CD19. So again, here's this exon 2 mutation. You can see that you have a truncated form that, these patients might either be seen as dim CD19 or negative for CD19 because you don't have the specific antibody to be able to detect it. And it's mostly cytosolic and hidden from T cells. And the hallmark of relapsed leukemia post-CAR T cell was lack of the full-length isoform. I will tell you, based on studies that are being conducted both at the NCI and the pediatric oncology branches, as well as other studies, that this is not the only mechanism, but at least one mechanism of loss of CD19. There's also lineage switch. So again, going back to one of those original slides that I sort of, talked to you about, where the lymphoblasts come from and the myeloblasts come from, we talked a little bit about MLL rearranged leukemia and how it may represent a little bit more of an immature phenotype, potentially a little bit more stem cell-like. These patients with infant ALL have a very, very poor prognosis. They have also been quite difficult to make CAR T cells from, keeping in mind that they're little, they're young, they have to undergo apheresis. Some of them may be as young as 2 or 3 by the time they have relapsed refractory disease. So the group in Seattle that was led by Rebecca Gardner et al., part of what was really remarkable is that they treated 7 such patients with MLL rearranged, and all of their patients attained an MRD negative remission following CD19 CAR-based therapy. So they're able to make CAR T cells and give them from this young population. And in 2 of these patients, when they relapsed, they actually were no longer ALL, but they were AML, and they had just shifted their phenotype, probably going back to some of their stem cell. And this is something you'll also see with blinatumomab, where it's MLL rearranged were treated with blinatumomab and with exerting this CD19-based pressure, and they seem to, reroute into myeloid phenotype. Eli Jacoby from our group, one of our fellows who worked in Terry Fry's labs, also was able to demonstrate that CD19 CAR pressure would induce lineage switch. And so if you're no longer lymphoblastic leukemia, again, that's another mechanism of completely evading the CAR-based therapy. To now spend a few minutes on CD22, I mentioned in one of my earlier slides when we looked at the immunophenotype of the different antigens on pre-B ALL, that CD22 tends to track right along with CD19. It's a 140 kilodalton B lineage differentiation antigen that is expressed on the vast majority of pre-B ALL. It's a targetable antigen for immunotherapy. I briefly mentioned eprotuzumab, which is a naked antibody that's had limited efficacy. It's sort of used in chemotherapy combination trials. Inotuzumab, which I mentioned, has a recent FDA approval in adults, which is a conjugated antibody conjugated to calicheamicin, and moxetumomab, which is actually developed at the NCI and is being most predominantly studied in hairy cell leukemia, but which we also studied in pre-B ALL. Based on us having a CD22-based therapy in conjunction with our flow cytometry team, we really helped to characterize the expression of CD22 in acute lymphoblastic leukemia. Which really had not been done in a uniform approach, at least for pediatric ALL prior to this. So this shows you our gating strategy. This study was done in the era prior to CAR T cell therapy, where we were able to gate on patients who were CD19 positive. So again, you have here on the y-axis CD10, you have on the x-axis CD19. This is our gating strategy to identify the leukemias. Panel B shows that patient with MLL rearrangement. So CD22 antigen expression is shown. The y-axis is CD19. You can see here quite a uniform expression of CD19, but a wide splay of CD22 antigen expression, again, speaking to the fact that some patients with MLL rearrangement have quite a variable distribution of CD22. Some may even be CD22 negative. This becomes very clinically relevant if you go now back to our discussion about the inotuzumab, where the specific patient population with the 411 translocation that did not have as good a response to inotuzumab, likely speaking to the fact that they may have had a partial CD22 population. And then shown here in panel C, D, and E is sort of the different degrees of intensity of CD22. Our flow cytometry team is able to quantify this. In general, we see a median site density of about 3,000. Can be as high as 10,000. It can be as low as 1,000 or in the several hundreds, which is vastly different from CD19, where the antigen expression in general is in the 8 to 10,000 range. So again, CD19 is shown at a much higher level on a pre-B cell ALL cell than CD22, even though it was uniformly expressed on all leukemia cells. Again, just talking a little bit about the MLL rearranged, not only do they have partial positivity, as shown here in this graph, again, CD22 is on the y-axis, you have CD45 just gating for white, white blood cells, and you see here that, again, 44% of this population is, based on our gating strategies, would be considered CD22 negative. We would not be enthusiastic about treating this patient with a CD22-based targeted therapy because you're only going to treat what you can see. These patients also have a median site density that's overall lower, which may become important as we think about going to targeted therapies. So based on our branch's interest and investment in looking at CD22, knowing that CD19 relapses were on the horizon, knowing that these patients were still retaining CD22, and that these patients would have exhausted all of their therapeutic options, our group in the pediatric oncology branch, under the guidance of Crystal Makel and Walid Hasser, really led these efforts, constructed a second-generation CAR that was targeting CD22. You can see here that the CD19 protein is really quite short. You can use multiple different scFvs to have an active CAR construct. But constructing a CD22-based CAR is actually a little bit more tricky. When we use the HA22 or the moxetumomab-based scFv, which is active as an antibody conjugate, it was completely inactive as a CAR. And ultimately, we ended up using the M971 scFv that, comparably to the shorter CD19, is a very proximal binding domain and showed preclinical activity. And based on the preclinical activity, this is a construct that was taken forward in clinical trials. We used the 4-1BB and the CD3 zeta signaling domain, and the 4-1BB was based by additional experience that we had gained over time in comparing the different CAR constructs that showed us that the 4-1BB is more persistent. And again, knowing that our patient population was to be highly selected for a CD19 negative population that had failed other therapies, we wanted to build a CAR that was there to stay. So we led a phase 1 study that was a 3+3 dose escalation. This is considered a standard phase 1 clinical trial approach where you treat one patient, start at the lowest dose level, you evaluate them for a period of time to make sure that they don't have some overwhelming significant toxicity before treating another patient. You'd only treat 3 patients at a dose level to give you adequate experience before going up to a higher dose level. We used the NCI-based construct. We treated patients between the ages of 1 and 30. We enrolled our first patient in 2014, and we utilized the same lymphodepletion strategy, again with fludarabine and cyclophosphamide, which is a 3-day regimen, as we had in our prior CD19-based trials. And what we found was really quite exciting. So again, we knew that CD19 was active. We couldn't take for granted that CD22 was going to be active. It was really the first new CAR in ALL, and we had known at that time that other CAR constructs in other leukemias or other solid tumors were not that active. But we found that CD22 CAR was active in CD19 negative, CD19 dim, as well as CD19 positive ALL. So shown here is an example of a patient who had a very highly involved marrow. This patient is CD19 negative, having received prior CD19-based CAR therapy. This is immunohistochemistry-based staining for CD79A, which is a pan-B cell marker. This shows, again, the pink is complete replacement of her bone marrow by leukemia cells, and this shows complete clearance of her leukemia at 1 month post-CAR therapy. You can see here, again, sort of looking at this same patient. This is, again, the grading strategy that we use that is based on, sorry, it's really small here. You see that she is CD19 negative, CD22 is positive. On day 1, she has circulating blasts, again, representing 9.5% of the cells. There's no detectable CAR T cells on day 1. By day 7, she has eliminated most of her leukemia. 11% of the CAR T cells are CAR positive. By day 12, she's completely eliminated all detectable peripheral blasts. 77% of the T cells are CAR positive. And by day 20, we continue to have no detectable leukemia. And again, you sort of see a peak expansion around day 12, and then sort of a slow regression of the maximal expansion of your CAR T cells. For more details, our paper was just recently published in Nature Medicine that will talk about the full details of the clinical trial. We found that we had a complete remission rate of 73%. We had actually limited cytokine release syndrome. So, the experience with CD19 was that about 50% of the patients would have high-grade cytokine release syndrome, which we said was grade 3 or grade 4, included in some degree of blood pressure support or respiratory support. We did not see that same grade of toxicity with it, which I think was interesting, and I think it showed you that there could be differences in antigen. Based on the antigen that you're using for CAR T cells therapy, some of our toxicity profile did differ some. So again, I think that there's going to be antigen-specific differences that we'll need to explore. We had very limited neurotoxicity, but again, as with the story of CD19, we saw that relapses were associated with modulation in CD22. Shown here is our dose escalation. I won't bore you with the details. We started at a relatively low dose, and we had a very low complete remission rate, so we had low efficacy. We went to a dose at dose level 2, which was 1 million CAR T cells per kilo. We had no significant toxicity and 100% complete remission rate. We went to the higher dose. We had toxicity. Didn't seem like the remission rate was any better. So based on low efficacy at the low cell dose, high toxicity at the higher cell dose, we then have proceeded forward with this sort of, the medium cell dose. This here shows the patient characteristics. I include only the patients who were treated at this middle cell dose just to give you a sense of who our patients are. 91% of the patients who were at this expansion phase had received prior CD19 CAR-based therapy. Somebody else had also developed a CD22 CAR, so 2 of our patients had received this construct as well. 55% of our patients were CD19 negative or dim. And the vast majority of our patients had a high level of disease burden. Greater than M2 marrow means that they had greater than 5% disease. Again, the vast majority were probably about 50% of their bone marrow was replaced by leukemia. So going back to our patients, and how did they come here and why did they come here? So our patient BJ, as you remember, is 18, in college, doing well, but is high risk at the time of diagnosis by his age and his white blood cell count, and has a poor response to chemotherapy. Had he been born a decade earlier, he probably would not have had the therapies that he had received and would have received clofiramine, had it not been effective. But he was at a time where he was able to get blinatumomab. He achieved a complete remission and went to hematopoietic stem cell transplant. But unfortunately, despite a very good curative attempt, his disease came back after transplant, and when it came back after transplant, he was very dim for CD19, and that was the indication for him to be referred to our protocol. As you may recall, was standard but did not have a great response to her upfront chemotherapy. She was allocated to the high-risk arm. At that point, she had a good response, but then towards the tail end of her chemotherapy treatment course had CNS disease, got more chemotherapy, but then subsequently emerged with bone marrow disease. She did go on to receive CD19 CAR T cells, attained a complete remission, and unfortunately went to transplant, and then after transplant also relapsed with CD19. That time she was CD19 positive disease, but the team that decided to then sort of shift gears, thinking that she could have a population that was sort of lurking behind the surface of CD19 negative disease. And then Sonny, he, at the time of relapse, CD19 was more readily available. He enrolled in a clinical trial, received his CAR T cells. They decided not to wait and did pursue a curative transplant with the intent of it being curative. He was actually in remission for almost 2 years. And then when he emerged, he was fully CD19 negative. And when I first met the family asked me, so where did the CD19, where was it hiding for the last 2 years? And I don't have an answer to that. But again, this gives you a sense of who my patients are, why they came, and how they came to us. So based on our early experience, this here again is our waterfall plot. This was just again published in Nature Medicine. We had one patient who, a few patients who were truly progressive disease, mostly at the low dose level. This one patient did have rapid disease progression, but he progressed before the CAR T cells were active. His leukemia started to spiral out of control essentially, the first day after his cells were given. So we were forced to give him chemotherapy to not have complications of his leukemia. So we never got to see the effectiveness of the CAR T cells. You can see here again the vast majority were complete remissions with, again, limited cytokine release syndrome, at least in this early experience. At the expansion phase, again, looking at the middle cohort, we had 17 of 22 had a complete remission rate. Our longest remission is now more than 2 years after CAR T-cell therapy. This is a patient who had received 2 prior transplants. So again, told you my patients are extremely heavily pretreated, and you probably wouldn't put, most adults would not be able to go through what my children are able to go through, but he's gone through 2 prior transplants. Going to a 3rd transplant is not an option. And we feel so grateful that he's in an ongoing remission with no interval therapy after receiving our CAR T-cell targeting CD22. For those who do relapse, unfortunately, we're seeing that happen at about 6 months post-CAR T-cell therapy. And what we learned is that, and I'll actually skip this because I'm going to come back to this in a few slides. In terms of CD22 antigen expression at relapse, so going back to CD19, when patients receive either CD19-directed therapy based on blinatumomab or CD19 CAR, it seems to be that they truly lose the CD19. And I'll use the term lose CD19 is very, very loosely. It's probably just not obviously detected on the surface. It's probably there still at the RNA or the DNA level. You just cannot visibly see it. With CD22, the experience with relapse is a little bit different. We are seeing that even just a diminution of the level of antigen expression on the surface is enough to evade the CAR T-cell response. So again, I talked a little bit about how CD19 expression is probably in the range on the surface about 8,000 to 9,000 in terms of antigen binding capacity. CD19 in general is about 3,000. Our gestalt is that you probably need, that there is some degree of a threshold effect. You probably need to have some degree of antigen there to get the CAR T cells to be activated and respond to. And when they fall underneath that threshold, they will likely evade the immune response. So going through some of these patients. So patient 2 here, you can see that there's this patient really lost her CAR T cell, so there wasn't much of a change there. But patient 8, again, this is a logarithmic scale looking at CD22 site density. You see here that there's just a drop, and at the time of relapse, these 3 patients all had circulating CAR T cells against 22, but again, just losing the CD22 expression. These weren't patients who were partial positive. They remained fully positive, but a lower expression. They all led to immune escape. We had one patient who developed 4 populations. This is a CD19 negative patient at the onset who at the time of relapse essentially had 4 populations. She had a population of CD19 and 22 positive, population was 19 and 22 negative, and then 2 populations that represented each of the combinations. So again, that just speaks to the fact of how much we need to learn in the era of immune-based targeted therapies. So our experience to date is that this really was the first successful CAR T-cell-based therapy for CD19 negative B-cell ALL. Our preliminary experience suggests comparable potency to anti-CD19 CAR-based therapy. The response did correlate with the dose level. We did not have any severe irreversible neurotoxicity with the cytokine release syndrome profile that was acceptable. Relapse was associated with changes in CD2 expression level. They did not have to become CD22 negative. And future directions is really, again, not that different from multi-agent chemotherapy. We probably, can't just target one antigen. You probably need to take a combinatorial approach to really keep the leukemia from coming back. So going back to our patients, I like to think of this truly as a bench to bedside, back to the bench. It is our patients who truly inspire change in terms of what we do and helps to move the bench progress forward. So patient BJ. So again, like I mentioned, he came to us having failed transplant, CD19 DIM. up until this point, there's a fair degree of variability in making the CAR T-cell product. You use one process, but everybody's CAR T-cell product is not going to be the same. There is a heterogeneity in the patient population. Despite this heterogeneity, we were able to successfully manufacture CAR T-cell products for 90% of our patients. He was not one of them. We could not make his CAR T-cell product. It was not expanding. We determined that there was inhibitory myeloid-derived suppressor cells and NK cells that were leading to this failure, but he had exhausted all therapies. So again, we needed to do something. So in conjunction with our clinical center cell processing section, they had already been exploring the concept of utilizing CD4, CD8 positive bead selection to sort of really purify that apheresis product that was selected up front to try to get rid of the additional impurities and the other contaminants that were left behind after the prior selection processes. We used this strategy. We were able to use that identical apheresis product collected from this patient at the initial time and create and manufacture a CAR T-cell product, infuse it, and it led to a complete remission for this patient. This is now being used for all of our patients moving forward. This is a protocol, from our protocol was probably amendment, J or K, but this is really our patient who inspired this change in real time. What we also learned is that somehow by increasing the potency of the starting product, we may by increasing the purity of this CAR T-cell product, we may increase the potency of this CAR T-cell product. So we found that even though we had a very acceptable safety profile up front, when we purified and used this T-cell selection process, our patients had more severe cytokine release syndrome. They had more complications. So we are now actually dose de-escalating and have found that the prior low dose that was ineffective is now effective using this new strategy. So again, these are things that we are doing in real time for our patients. And again, this is a whole avenue that needs to be explored. Intensified lymphodepletion. So this is Sonny. His first CAR cell infusion, he sort of had an incomplete response. He did something. He had cytokine release syndrome, but there wasn't really good expansion. One topic that I did not touch upon at all is that for those patients where there is CAR T-cell failure and they still express the antigen, second infusions have generally not worked. There is some thought that once your body sees that CAR T-cell, that your body mounts an immunologic response to reject that second infusion. So approaches being used to overcome that are, the initial CAR construct for murine-based. So if you had a murine-based CAR, to try a humanized-based CAR, to try different strategies. For this patient, again, he had exhausted at this point all therapeutic options. I forgot to mention he had even received inotuzumab before coming to us and a prior CD22 CAR that had not worked. So we were sort of his last hope. It sort of worked, so we said we want to do something different. So we actually tried an intensified lymphodepletion strategy to say, can we use more lymphodepletion to overcome this immune-mediated rejection? And it worked. And we now use this strategy for all second infusions moving forward, and just put this together as an abstract because this is a strategy that we are going to use for patients who relapse with CD22 positive disease who have lost their CAR to see if we can get their response to come back. Again, keep in mind, my patients have been through so much that they are really at the end of all therapeutic options at this point. And then this sort of 1-2 punch. So this little girl, she relapsed with CD19 positive disease. We treated her. She was in a remission, but she relapsed 6 months after therapy. We tried a second infusion prior to our intensified approach. It didn't work. She was still CD19 positive, so she went somewhere else, got another CD19 CAR T cells. Those T cells did not engraft. She was still in a brief remission, and now most recently she's relapsed. And we know, just doing the 19 after 22 after 19, this is only going to be sustainable for so long. So we are actively working on bringing a 1922 bispecific combinatorial strategy, and we are weeks away from being open to enrollment. Again, with the idea being we want to target these things at the same time. And so this is our construct that we're taking forward. This is a phase 1 dose escalation study of anti-CD19, CD22 CAR T cells. It's a bispecific construct, one CAR with both 19 and 22 on it, with the hypothesis being that simultaneous targeting of 19 and 22 could diminish the risk of antigen loss escape. And we're just waiting the final sort of IRB approvals and hoping to be open and enrolling our first patient which will likely be one of our patients who has come through one of our prior trials later, next month. You can see here again sort of the preclinical efficacy. This is a CD19 CAR. This is a CD22. This is our loop CAR showing, again, comparable efficacy against CD19, CD22 positive leukemia. This CAR is also in preclinical settings, so you can take a bispecific CAR, have it work against CD19 negative disease, it'll target the 22. We're working at CD22 negative disease, it'll target the 19. And again, our goal is to really treat patients who are 19 and 22 positive. Just to shift gears a little bit, I think the next frontier is to shift gears and think about AML. So ALL really is a poster child for leukemia, and I think, the progress that has been made in the recent era, it is remarkable. The next frontier is really AML. AML represents 20% of childhood leukemia. It is 6% of childhood AML is 6% of all AML, so it really is more of an adult disease. Overall survival is 60 to 70%, much lower than that 85 to 90% that I talked about with acute lymphoblastic leukemia. Cytogenetics have an essential and a huge role in diagnosis and prognosis, and there's a lot being studied in terms of the molecular evolution and clonal evolution with AML. Very, very intensive therapy, and relapse is the greatest cause of failure. Thinking about AML and targeting that as CAR therapy. Again, overall outcomes are about 50 to 70% overall survival. The immunophenotype is much more variable. So AML is as a subtype, it's a much more heterogeneous disease. CD33 is found on its surface. It is a target for gemtuzumab, which was FDA approved. Again, that's an inotuzumab version conjugated to calicheamicin. We know that it's active for patients who are CD33 positive. CD123 is an alternative target. Going back to the concept of CD19 or CD22 targeted therapies, a CAR T cell cannot differentiate between a normal CD19 B cell and a leukemia CD19 positive B cell. But you can support prolonged B cell aplasia by giving these patients IVIG, and many of them are going to continue to be in IVIG. The problem with myeloid leukemias is that, myeloid aplasia as a result of targeting CD23 on a non-leukemia cell is much more difficult to manage. And so we don't really know what's going to happen when we start targeting CD33 and what their period of myeloid aplasia would be. In this case, you may want a shorter acting CAR, or you may want to move immediately to stem cell transplantation to restore an aplastic marrow. And so what I'll say is that we are actively working on developing an AML CAR trial that I hope would be available by this time next year. And again, it's based on a construct that was developed in Terry Fry's lab that I'll be bringing out to the clinic. And that's sort of thought, we're hoping to do that as a limited center study and then potentially move it forward. So going back to the question of, will CARs be the answer? I think not for everyone. I've mostly focused on antigen loss and so talked about what we need to do there. I think combinatorial strategies are needed. CAR cell failures, I think we're looking at different avenues to optimize that. There's other things that are being done on the tail end to try to see what you can do to improve CAR T cell persistence. Inability to manufacture CAR T cells, we are very happy with what we're doing right now. We're able to produce products from patients who have not been able to be manufactured somewhere else. Actually, again, speaking to very, very real-time news, we were recently referred a patient for whom CAR T cells could not be manufactured at other institutions. We said, look, we'll try it. We've used a different strategy. It's worked before. He's had 2 prior attempts where CAR T cells could not be manufactured. And I learned just minutes before this presentation that we were able to manufacture CAR T cells for this patient. So again, it's just, again, our stuff, exactly. It's really in real time. And then again, like I said, I think the whole avenue of toxicity needs to be explored. So future directions, I think we're looking at novel CAR constructs, AML CARs, bispecific CARs, optimizing second infusion. If you have the antigen, we should be able to find a way to make that infusion work. We make so many CAR T cells, the extra CAR T cells are just stored in the freezer. We'd like to improve the CAR persistence, but the persistence isn't going to be helpful if you evade the CAR. We are looking at other strategies. So one of our senior fellows, again in Terry Fry's lab, and I'll be bringing it out to the clinic, we're looking at trying to find ways to increase the tumor sensitivity to CAR T cells. So we're looking to explore, can you, so with CD22 being more modulatable, are there things you can do to sort of increase the level of expression of CD22? And if we can do that, can we use that in conjunction with CAR to make that CAR more active, more persistent, sustainable? So hopefully we'll be bringing that out into the clinic this fall. The patients we've treated thus far are all multiply relapsed refractory disease, but again, knowing that about 10 to 15% of patients will relapse and this therapy is effective. I forgot to mention that patients who have a higher burden of disease will have more toxicity from CAR, because again, there's more leukemia to fight. Patients with low burden disease have less toxicity. So can you take this CAR construct into patients who are at high risk disease early in their therapy and use it to improve their survival, make it safer, make it more persistent? So that's going to be an upcoming Children's Oncology Group trial to bring this strategy for patients who are high risk. And can you potentially even spare them the toxicity of transplant if you could really induce this durable remission? And I think, my gosh, the future, I think, is just, I don't know what the future will hold in terms of the potential of what this therapy could bring to the treatment of ALL. I did not talk much about lymphoma. Again, I mentioned that the CD19 CAR is FDA approved for lymphoma. In pediatrics, we have not seen and experienced the same response. So on our current protocol, we have a separate lymphoma arm. We have a separate arm for specifically patients with CNS disease. There's a reluctance to treat patients with CNS disease given the neurotoxicity, but we were one of the first institutions to treat CNS disease. In our experience, at least our first patient who had isolated CNS disease, the CAR T cells go to the CNS. We see them in the spinal fluid. We know they go there, they're active. And our patient is in an ongoing remission for at least a few months now without significant CNS toxicity. I think we need to learn about how to decrease toxicity and just thinking about ways. Are there, can you put in like a suicide vector or gene into the CAR T cell? So instead of using steroids that would reduce the efficacy, can you do something to turn it on and turn it off? And I think we need to improve access to therapy. And by access, I mean not only the ability to collect CAR T cells, to make CAR T cells, but I think you all have heard about the price point of the current FDA approval, which is close to about $500,000, and getting the insurance approval, getting it to a specialized center. So I say it's FDA approved, but it's still not easily available for everybody. And I think over time, thinking about different ways of manufacturing it to make it less effective is what really needs to be explored to make this a more widely available therapy for all. Many, many, many people to thank. I'd like to thank you all for inviting me to come speak here today. I think it's a really exciting field that I feel very passionate and lucky to be involved with. I'd like to specifically thank Terry Fry, who has been my mentor and partner in doing this work as I bring it out to the clinic. Brigitte Wiedemann, our branch chief, John Glauder, clinical director, Haneen Shalabi, who is will be a staff clinician with our group, and the rest of our clinical team, and really just the NCI, the clinical center, our cell processing facility. This really is a concept of it takes a village. There is not one single person who I can say gets all of the credit. It is a team effort, and we could not do this without every member of the team. Our apheresis, our referral patients, and then I will ultimately say a special thanks to all of our patients, particularly those who are no longer with us, their families and their referring teams. And I think that, for my patients, their memory lives on in our work. And it inspires us, and we have protocols based on our changes based on our patients and how they inspire us to move forward. So thank you.
Well, we have time for a few questions, and maybe I can start by asking you, it really is a very difficult task in approaching patients who already been treated with multiple chemotherapies and had a lot of difficulties in recovering their bone marrow. So what are the sort of new frontiers of identifying a little earlier really high risk, that 1 out of 5, 1 out of 10 patients that ultimately end up in your hands?
Yeah, so I think you got the sense, at least from the first 2 patients, both BJ and MM, they declared themselves as high risk after the first month of chemotherapy. So I think if you could take that patient at that time point when they've received chemotherapy, they've had a suboptimal response, if you could take them to an apheresis, collect their T cells when they're healthy and not so beat up. Again, my patients have come, the very first patient I treated on the CD22 CAR protocol was a patient who had had leukemia on and off for 2 decades, just to give you a sense of what our patient population is. But I think, again, response to therapy is imperative, and if you can identify some of these patients, before you stratify them into the higher risk category, collect their T cells and see that you can use them for the future, because they've sort of declared themselves already. And again, we have criteria. We already have a designation in terms of patients who relapse who needs to go to stem cell transplant. So I think if you can incorporate those same risk criteria, you can probably identify those patients who would benefit from earlier consideration of CAR T-cell therapy.
Following up with that, if you did bank back the CAR T-cells when they're first diagnosed, would that have a positive effect on the cost of therapy to lower it for that access to care?
I don't know. I think a lot of the cost of care is really in the manufacturing of the CAR T-cells, so I don't think that would change. Because you can store the apheresis, it sort of makes it a little bit more feasible to get the T-cells earlier on before they're so beat up, but I don't think it would necessarily manufacture. The main cost is sort of the vector production and the manufacturing.
Thank you. How have there been any studies on how long these CAR T cells last in an individual, and kind of hand in hand in that? Unfortunately, you can't specifically target the CD22 or CD19 positive cancer cells, but you're targeting all of the B cells in general. What kind of repercussions is that for a patient, eliminating what I assume is their whole B cell repertoire?
And so that's what I was alluding to. That's the big scary thing about an AML CAR, because you can't really survive not having your myeloid lineage. That's not acceptable. With B cells, a lot of our patients end up on chronic IVIG or subcutaneous immunoglobulin replacement, and that seems to be survivable. One of the proxies we use for the potential of disease to come back is if their normal B cells start to come back. And you start to worry a little bit, because you're like, well, if the normal stuff is coming back, is sort of the abnormal leukemia just on moving forward? And so I think, and again, everybody has done things a little bit differently. We had a short-acting CAR. We did not expect it to last very long. And so B-cell recovery was something we saw. And a lot of our patients went to stem cell transplant because we didn't expect that the CAR would remain long enough to keep the patient in a good remission. With other CAR therapies where they have a more persistent CAR, you're looking at markers for what could predict, and so you are looking for CAR T-cell persistence. I will say in our patient, we use 2 modalities to look at CAR persistence, both by flow cytometry and PCR. But in PCR, we don't have all of our data, but I can say at least for the patient who's in an ongoing remission, we saw something very interesting, and I think that this speaks to the fact this may be like a living drug. And I certainly have seen this with my lymphoma patients, where you may see the CAR T-cell sort of expand and regress with time. So our patient who is in remission now more than 2 years, we did not detect CAR T-cells in the bone marrow by flow cytometry at 12 months, and at 18 months they were back again. We didn't give more CAR T-cells, we could just detect them, and once we look, and the PCR data sort of corresponded to that. Patients with lymphoma, the few that we have treated, it seems to take them a lot longer to have a response, but you will often see a pattern if you have an initial expansion, some regression of their leukemia, and then you just seem to have these waves of expression where I feel like they're just continuing to see the antigen, and there's more sort of stimulation for expansion. So it's all in evolution.
Well, thank you, Dr. Shah. That was very enlightening and certainly very challenging field. So if a few of you want to talk to her personally, I'm sure she'll be here for a few minutes. Thank you very much, everybody.
Thank you.